Hello, and welcome to Precision Athletic Training Home Study CEUs. I am Megan Hunt, the Vice President of Precision Athletic Training, and I'm happy to have you logged on today. Precision Athletic Training provides quality and convenient athletic training services for sporting events. We were founded in 2009 and began providing CPR and CEU opportunities for athletic trainers in 2013. Please note that the course evaluation form and assessment form are posted on the same page as this video. Please remember to download them, fill them out, and email them to me at mhunt@precisionat.com. When I receive these, I can then email you your statement of credit for the course. If you have any questions, please email me or call me at 781-366-1880 during normal business hours. Our presenter for the Concussion series is Cassandra Johns. Cassie earned her undergraduate athletic training degree at Florida Southern College and her master's in science at Georgia Southern University, focusing on concussion research. Her thesis was focused on the prediction of concussion utilizing baseline assessment tools, which she presented on at NATA in St. Louis in 2015. Along with this, she's also the second author of The Role of a Certified Athletic Trainer/Therapist in Concussion Management, which is published in Current Research Concussion, a Canadian research journal. Without further ado, Cassandra Johns.
Hello everybody, and thank you for tuning in to the last part of our 4-part concussion lecture series. In this lecture, we'll be focusing on late life impairments. As Megan said, my name is Cassandra Johns. If you have any questions, please do not hesitate to email me at Cassie with a K at precisionat.com. So without further ado, let's get started. So I'd like to start off this lecture by going over the Concussion movie trailer. At this point, the Concussion movie is out. I'm not sure who's seen it. I haven't gotten a chance to see it yet, but I'm sure we've all seen the backlash articles. But considering we're going to be having some obstacles with this movie, I'm sure as a profession, I wanted to start off by showing you the trailer in case you haven't seen it.
When I was a boy, heaven was here, and America was here. You could be anything, you could do anything. I am the wrong person to have discovered this.
If you don't speak for them, who will?
I found a disease that no one has ever seen. Repetitive head trauma chokes the brain.
The NFL does not want to talk to you. You turned on the lights and gave their biggest boogeyman a name.
You're going to war with a corporation that owns a day of the week.
No proof was presented today because there simply isn't anything.
They have to listen to us. This is bigger than they are.
What do you think they're doing to you now? That's nothing. You have no idea how bad this could get.
I have to keep going.
They want you to say you made it all up.
If they continue to deny my work, men continue to die.
Sometimes in life, you're asked to leave it alone. But sometimes you can't.
Who are you? Tell the truth. Tell the truth.
Okay, so just to begin this with a disclaimer, I'm not using the video for any actual facts, but I wanted to show it because Hollywood has a way of pulling things a little bit out of proportion. CTE is a real concern, as are the late life impairments, but they're not going to happen in everybody. And the way that movies tend to portray it is everybody who plays football is now probably going to get CTE. And as we know, that is likely not the case. So this will heavily focus on CTE because it's what you're going to hear about the most in the media. It's definitely what we're going to deal with the most as athletic trainers following this movie. I'm sure we're going to have a lot of parent questions, even following into So this lecture will heavily focus on CTE because it's what we're going to hear about most in the media. Even following this movie, I'm sure we're going to get a lot of backlash from parents. I'm sure we're going to have a lot of questions from parents come youth football season, high school football season. The movie, in my opinion, is probably going to elicit some rule changes that haven't quite happened yet, but have been on the fence for a while. I know we've all heard about the discussion of limiting tackling until you hit a certain age. Typically high school age is where you'll hear it, 12 or 13, for teaching kids how to tackle. Hockey doesn't allow hits until that age either. So just some food for thought. So to start off, on the left is a cut normal brain. You'll see where the blood flow goes and just how it looks like a normal healthy brain. On the right is advanced CTE. You'll see that the brain looks like it's degenerating. It's kind of an orangey brown. You're going to have much bigger gaps throughout that you don't have over here. So that's just to kind of orient you as we continue to go through this. So what late life impairments are we concerned about in the medical field? Well, we're concerned about CTE, which is chronic traumatic encephalopathy. You probably won't hear me say that a lot. I'll abbreviate it as CTE pretty much straight through because I don't want to mispronounce it, and it is a bit of a mouthful. You'll hear about ALS, amyotrophic lateral sclerosis, Lou Gehrig's disease. You'll hear about depression, Alzheimer's, and any other mental disorders or other forms of dementia that might arise. Alzheimer's is the most common form of dementia kind of as we go through this. So to orient you, I'm sure you all know the anatomy of the brain, but because we're going to be talking about the brain so much and we're going to be talking about CTE, I wanted to kind of orient everybody. So you have the frontal lobe, you have the motor area of speech, you have the temporal lobe, the parietal lobe, your reading comprehension area, your sensory speech area, your occipital lobe, your cerebellum, the medulla oblongata, the pons, and then coming from the top, you have the frontal lobe again, the premotor area, the precentral gyrus, the postcentral gyrus, the parietal lobe, and the occipital lobe. I know we had to color code this when I took high school anatomy. I don't know if anybody else had to do that, but that's kind of how I remember it, is the colors. These are pretty typical colors when you have to color code it. So just kind of a fun fact. So to go into chronic traumatic encephalopathy, or CTE, it is the punch-drunk disease. It's something that for a long time we only saw, or only thought we saw, in boxers after getting repetitively punched in the head or slammed down on the ground. They would appear to be punch drunk, and this is kind of how they lived their life. And later on, it came out that this was actually chronic traumatic encephalopathy. So it's a progressive degenerative disease of the brain that's found in athletes and others with a history of repetitive brain trauma, including symptomatic concussions as well as asymptomatic subconcussive hits to the head. CTE has been known to affect boxers since the 1920s. So when you're thinking about the asymptomatic subconcussive hits, you're thinking about heading a soccer ball, getting hit in hockey without suffering a concussion, getting hit in football without suffering a concussion. Any hit that looks like it could alter the brain function, or any direct hit to the head can be considered a subconcussive hit, which is a reason why a lot of the rule changes have been discussed kind of across the board with sports, excuse me. So what do we know now? I mean, you have professional football players sustaining concussions and presenting with CTE. You have high school and college football players presenting with CTE. So there was a suicide of Andre Waters. He was the third NFL player to be diagnosed with CTE. He was 44 years old. He died on January 18th, 2007, and made the New York Times front page. Then you had Mike Webster at 50. Everybody's heard of Mike Webster. He's in the Hall of Fame. He played for the Steelers. He was a center, and he died homeless. And then you have Terry Long, who was 42 when he died, and Ted Johnson, who made the front page of the New York Times and Boston Globe in 2007 on February 2nd. So what did these men have in common? What predisposed them to CTE, and what made us get to the point of dissecting their brains and deciding that they had CTE? These four men were the Iron Men of football. They were the people who would get up from hits like this where the helmet flew off. They were the people that exhibited no blood, no foul, push through it, be tough. All those thought processes that you hear about in football, and you even hear it on the sidelines of youth football. If it's not broken, get back on the field, which, I mean, we don't say, but how many of you have heard a coach say that? How many of you have heard a coach say, oh, you just got hit in the head, you're fine, and push them back out? How many of you have had an argument with a coach that a kid has a concussion where the coach has said, oh, no, he's fine, he just has a headache? Or, oh, no, he's fine, he just needs to shake it out, he had his bell rung. That's what these men alluded. They were the professional football players that showed if you just rub some dirt on it, you're fine. They had sharply deteriorated cognitive function throughout the last few years of their lives, especially recent memory loss. And they had major psychiatric symptoms like paranoia, panic attacks, and major depression. Their whole lives had changed because of their blows to the head. But was it their blows to the head, or was it the mismanagement of the invisible injury that we just started to take seriously in the past decade or so? So all of these brains were, in fact, examined by Dr. Bennett Amalo, who is who Will Smith plays in the film. Recently, there was an 18-year-old high school football player. I have a picture on the next slide, so we'll go into that kind of in a second. But Dr. Amalo is the one that discovered this in the NFL. He discovered it in football. Maybe it's not incorrect that there was a lot of backlash coming from that, but from my understanding, it is heavily dramatized. So, where is the research going with this? Well, unfortunately, we're not going to know how many football players or how many athletes in general suffer from CTE because we can only examine them after they've died. So, when they donate their brain to research, the good people at the BU Concussion Research Center cut into their brain and examine and look for that tau protein, which we're going to talk about a little bit later. I thought this picture was really interesting because it shows the activity that could be happening during the actual hit. Okay, so here's the brain of the 18-year-old high school player whose family has decided that he wants to be left anonymous. Therefore, we obviously don't have his name. So in the top left picture, you have a whole mount section of the frontal cortex showing very focal depression of that tau protein around small blood vessels. So if you look here, you have the tau protein in brown. It's squared in red. This came directly from the, excuse me, the Boston University CTE research website. In the bottom left, this is heavily magnified. It shows dense tau immunoreactive NFTs around small blood vessels and extensive tau immunoreactive neutrites and neutrophil immediately surrounding the area. And for those of you that don't know what NFTs are, they're the little holes that you're seeing here. In the top right is another whole mount section of the frontal and insular cortex showing very focal deposition of the tau protein around a small blood vessel in the insular cortex. And down here is that magnified picture again. So it shows dense tau immunoreactive NFTs, again the holes, and tau immunoreactive neurites in the neutrophil immediately surrounding the area. And this is kind of what CTE looks like. And when you break it down, it is scary. It can't currently be diagnosed on an MRI. I know when I was working last year, one of the coaches I worked with was like, oh, I should go get an MRI and figure out if I have CTE or not. I've gotten hit in the head a bunch. And I was like, that's not really how that works. But I'm glad that you at least recognize what CTE is and you take concussion seriously. So, I mean, it was a step in the right direction. He was definitely misinformed, but I think it's good that coaches are starting to realize the seriousness of concussions, especially when, just over a decade ago, we were still allowing same-day return to play. So here's a table that talks about the major components of chronic brain damage and dementia phlogistica. Sorry, I apparently can't say that word right now. It's punch-drunk dementia. It's also known as CTE. The areas damaged and the clinical signs and symptoms. So these are important, so I'm going to read through them real fast. The septum pendulum, adjacent paraventricular gray matter, front and temporal lobes are going to show an altered effect of emotional ability, or euphoria, and memory. Any degeneration of the substantia nigra is going to show the Parkinson's syndrome of tremor, rigidity, or bradykinesia. The cerebellar scarring and nerve cell loss is going to show slurred speech or loss of balance and coordination. And diffuse neuronal loss is going to show loss of intellect or Alzheimer's syndrome. So CTE can be diagnosed as Alzheimer's while they're living. And it's not until further examination that we realize that it was a different form of dementia, or it could have been the two together. I don't know of much research that's looked at the possibility of them being adjoined. So let's talk about amyotrophic lateral sclerosis a little bit. Just a little background on me so you know why I know so much about ALS. So when I was in college, I worked on a case study of a golfer that ended up being diagnosed with MS. His differential diagnosis included ALS. It included meningitis, and it included a few other neurological diseases. With that, we had to do extensive research into what ALS was and kind of where it came from. It's a nervous system or neurological disease that causes muscle weakness and impacts physical function. It's a type of motor neuron disease that causes nerve cells to gradually break down and die. In the United States, ALS is sometimes called motor neuron disease and is also known as Lou Gehrig's disease. Sorry about that, I didn't mean to switch to the side. So ALS is, again, what Lou Gehrig was diagnosed with. There has been some speculation in a couple of recent studies I've read, and recent books that I've read, that speculate that there's a possibility that Lou Gehrig did not have ALS. They speculate that he could have had a form of CTE. Lou Gehrig was your baseball player that was known for getting hit in the head. He took a lot of pitches to the head, and as we know, helmets weren't what they are now. So with that being said, there is some speculation in that. I thought it was kind of a fun fact that people might want to know about. So there's that. So you're also looking at depression, and we're not talking about just your generic depression. This depression is going to be slightly harder to cure because it's as if the neurometabolic cascade never stopped. And for those of you that didn't tune into the first lecture, we'll go on a quick idea of what the neurometabolic cascade is. The calcium and potassium pump works overtime, causing an influx of potassium in the cell, or in the brain, I should say, and in the cell. You then have an increase in ATP, which causes potential cell death, and with that, you continue to have the sodium-potassium pump working overtime, having that influx of potassium, and it causes a depressive state of the brain as well as altered neuron transmission. So it's a direct result of the regions of the brain that are injured, according to some Pitt research. So this isn't just your basic chemical imbalance depression. This is directly caused by the concussion. This is a picture from Pitt research that shows the area of the brain that could be affected with this. It's going to be slightly harder to treat with medication than regular depression. So moving into Alzheimer's. So we're all familiar with what Alzheimer's is. It's a type of dementia that causes problems with memory, thinking, and behavior. Symptoms are usually going to develop slowly and get worse over time, becoming severe enough to interfere with some daily tasks. So this is a normal brain. This is the normal brain cross-sected. This is what an Alzheimer's brain looks like. So it almost looks like it's withering away. And then this is what the slice looks like. I want to show you the slice because it doesn't really look all that similar to CTE, even though the presentation can be about the same. But this is pretty key because that's what you see in CTE. And the spread here, you're going to see in CTE as well. This is another scan that shows a normal brain, a brain with some mild cognitive impairment, and then Alzheimer's disease. So you're seeing all the activity that goes on through here, seeing slightly less activity through the midsection of the brain, and you're seeing absolutely no activity through the midsection of the brain here. Excuse me. So another thing you're going to look at is dementia. You're going to have a chronic or persistent disorder of the mental processes caused by brain disease or injury. It's marked by memory disorders, personality changes, and impaired reasoning. You can test, again, dementia is very commonly associated as Alzheimer's. You can test to see if somebody is a carrier of the disease or not. That can help determine whether it's potentially CTE or Alzheimer's. However, there's no real way, just to reiterate, there's no real way to diagnose CTE at this point pre-mortem. So non-carriers are going to look more similar to this. A pre-symptomatic dementia brain, it's going to look like that. You know, your mild symptomatic, and then your actual dementia. So I just want you to notice the changes that are occurring kind of throughout that. So what's the link? What's the evidence that associates concussions with these late life impairments? And you're seeing all these studies. Most of these studies are related to CTE because that's pretty much the focus of this lecture. The more you get hit in the head, the more your brain's going to be damaged. So when you're looking through this, any subconcussive blow is going to potentially elicit some form of that neurometabolic cascade. Any concussion is absolutely going to elicit that cycle of the neurometabolic cascade. Undiagnosed concussions are going to put people at a higher risk because they're playing through their concussions. Mismanaged concussions are going to put athletes at a higher risk because, again, they're playing through that concussion. We're going to look how the Amalo study started in 2005, and they caused all that media coverage then, and they're starting to cause more media coverage now. You know how the Center for Study of Traumatic Encephalopathy at BU, looking for the link constantly, they have collegiate players and high school players and professional players donating their brains to science on a regular basis. And they're making some big groundbreaking moves as far as that goes. You have the correlational studies that look at the fact that this person's had X amount of concussions, or this person's played a contact sport for their entire life, and now they're exhibiting these symptoms. Guskowitz did a study at Chapel Hill where he sent these questionnaires to these NFL players, and I believe he sent them once and then sent them again a few years later to see if they would report the same amount of concussions. Some of the players didn't respond a second time. Some of the participants reported completely different numbers, kind of eliminating the reliability of self-report at that point. But some of these athletes had such different answers in their questionnaires that it became pretty concerning that they might have some late life impairments going on. And the research really picked up on what was going on with the late life impairments. You have the quote from Lou Gehrig that said, "I may have been given a bad break, but I've got an awful lot to live for." And he was known for inspirational quotes like that. That's kind of why I put it there. But he also got hit in the head consistently with the Yankees. So again, you're looking at all the stuff going on. Did he really have ALS or was it CTE? And at this point, we'll probably never know. But there definitely is that speculation out there. And I can't remember the exact article that I read that in. I believe it was a couple because I also read it in a book that I recently read. If you're interested in that, I can try to find it for you. But the biggest point here is that the links are there. The evidence is there. But now we have parents questioning whether their kid's going to get CTE or whether this kid's going to have certain late life impairments. It's important when you're educating the parents that you don't emphasize the fact that if their kid returns too early, they could get CTE. That's a bit of a jump at this point. We don't really know the exact cause of things. We can't diagnose until post-mortem at this point. So where it's important to understand these late life impairments, I think it's also really important to remember that we can't be overplaying these to the parents and we can't be overplaying these to the athletes. I think it's important to educate them that this could happen if you're kind of in that point where they're really pushing for their kid to go back in and you're like, okay, well, these are the right now risks and these are the potential down the road risks. But they absolutely should not be emphasized in the educational protocol. So how can we prevent this stuff from happening? Helmets aren't going to prevent the concussions. They could potentially be helping with subconcussive blows. I don't think there's enough research at this point to make that conclusion. You have the HIT system, which is helping measure the subconcussive blows. It's helping measure the hits that are actually eliciting a concussion. So that's important for those of you that aren't familiar what the HIT system is. Put little accelerometers into the helmet. They're these little pads that clip or stick right in, and they go right onto a computer screen. So it allows you to see the force that each athlete is getting hit with when they're getting hit. So that's one of those things that is really important at this point to consider. You want to make sure your athletes are fully recovering. I kind of mentioned in one of the other lectures that one of the things my graduate director was looking at, and it was really interesting, was the role of gait in recovery. We learn to walk at such a young age that that's not something we tend to be able to change or fix or correct. So he would have them, the athletes that were participating in the study, walk down the gait right system at baseline, and then he would have them follow up post-concussion for weeks following return to play. They would not be following up every single day, but he had set marks on when they were supposed to follow up. And at that point, he started analyzing data when he had enough athletes. He had controls and experimentals. One of my classmates did her thesis on the gait right system and recovery, and she had controls, and you had to be somebody who exercised regularly because that's what the athletes were doing. But then you had to take the same amount of time off that the athlete did to see if your gait was altered because of that. She did find that the gait was not necessarily recovering when we were returning the athletes to play, which raises the question that our current protocols might not allot for enough recovery. And that's just something that future research is going to have to continue to look at to help prevent these potential late life impairments and the potential immediate risks of returning too early. With the gait being altered, that could help explain why following a concussion, you're at a 1 to almost 4 times greater risk of sustaining a lower extremity injury following return to play. It could be because you're not fully recovered and your gait is still altered. It's not something at this point that we can rehab because, like we said, we learned to walk at such an early age that it's really hard to alter that and fix that, especially following a concussion. The diagnosis and management of concussions is going to decrease the risk of these late life impairments. So having those baseline assessments, following up with the athlete. If you see an athlete that gets hit and they don't do anything, then, or they don't say anything to you, then go up and check on them. I know I've worked a couple of basketball games where the kid falls and can hear their head hit the court, and they get relatively right back up. They shake it right off and resume playing, and the refs never stop the game. So the second I can, I go and check on that athlete and make sure that they're not showing signs and symptoms of a concussion. And sometimes the coach gets irritated because the kid's saying they're fine and I'm making them go through a mini diagnosis or a mini evaluation to make sure that they haven't sustained a concussion. But in the middle of a game, you can't always rely on the athlete to forthcomingly tell you or be forthcoming about their injury, especially if they feel like they're a crucial player to the game. You see a lot in the better athletes, the ones that are just naturally talented, that they're not as likely to come right back out because their team's kind of depending on them. They might be one of the best players, and they don't want to be the reason why we lose the game. So you really need to kind of pull teeth with those athletes and make sure that you're not missing a concussion just because they're not coming right over to you the second they hit their head. I think at this point, it's pretty common to say, okay, hit my head, I'm going to have a headache. I mean, everybody's going to have some level of a headache after smashing their head on the court, but what's the cause of the headache? Is it superficial? Is it just a bruise on their scalp? Or are they eliciting other symptoms? Are they showing other signs? What are they acting like? How are they playing? Has their play altered at all? That diagnosis and that initial recognition is huge in potentially preventing any late life impairments. Limiting how many times a kid has the soccer ball, limiting when you teach them how to have the soccer ball because of neck strength, their cervical strength, or core strength, limiting when a kid can learn how to hit in football, and limiting how they hit, making sure that their form is great. I worked with one youth football team this past fall. That was fantastic. The coaches almost never yelled. But every time the kid tackled incorrectly or led with their head, they were pulled immediately off the field and yelled at. And where I don't think yelling is always the best mechanism of getting your point across, if you're going to yell at the kid and you're going to choose one thing, at least it's something that's helping their safety. I was really impressed by the way the coaches worked throughout. They were big into preventing any type of injury that was going to hold their player off the field. And I haven't seen that in many youth leagues, so it was nice to see. Management of concussions. So, especially if you work for us, you might be at a school only one time if you're one of our independent contractors and you don't follow up with them, or we have clients where we just cover their games and not their practices, so you don't get to follow up with the athletes as much as you would like. Trying to make sure that you're on the same page as those coaches and administrators on their return to play protocol is going to be huge. Making sure that the parents are on your side on taking them to the doctor for a follow-up. Making sure that the coaches are on your side with the progressive return to play. There's nothing more concerning, and I've had it happen, where you diagnose a kid with a concussion, you're back at that school the following, say it happens on a Thursday, you're back to the school on the following Tuesday, and the kid's already back to play. And with our protocol, there's no way that can fall into play on them already being back. Then you follow up with the kid, and they're like, oh, well, I told coach that I didn't have any symptoms, or I said this, or I said that, but come to think of it, my head kind of hurts when I run, or when I exercise, I get dizzy again. And those are things where it's, again, a lack of education. They don't have somebody there advocating for them on a full-time basis. And unfortunately, at this point, it's definitely a budget reason why schools don't have somebody advocating there on a full-time basis. But if you make sure you're on the same page with the coaches, that happens a lot less, especially if they know that you're coming back and they're going to see you again. So the management of the concussions is going to help prevent so many things, especially the depression that's going to happen or could happen later, or any memory problems that might happen later, the returning to learn aspect of things. I know I said something to a coach one day where I'm like, well, did you ask the kid how their day in school went? And they were like, well, no. And they said that they felt fine, so I assumed that they felt fine. And when I followed up with them, the kid was like, oh, well, my head hurts. Or it doesn't hurt now, but it did when I was in math class. Or, I was really okay, but I was taking this test in English and my head started pounding. Those are the things that kids don't think to be forthcoming with unless you ask, especially when you're working with a younger population. And if you can nip this stuff now, they're going to be at a much smaller risk of potentially having these issues later. Recovery, diagnosis, management, it's huge. And I know I'm harping on it a little bit, but I guess I firmly believe from the research that I've read that if we manage things correctly the first time, the kids are going to be at a much decreased risk throughout their life of having all these other issues. I know when I'm going through my return to play protocol, their first day of partial practice, if they're a soccer player, they're not allowed to have the ball. Their second day of non-contact practice, I tell them the same thing. Don't have the ball. They can't head the ball until their contact practice. Football, sometimes I'll have them not wear all of their equipment for their first practice to make sure that they're not accidentally having that contact happen. They're not getting caught up in the practice enough. Excuse me. That's all going to relate back to the management of concussion and how it works. especially when you're looking at the long-term deficits that we kind of know happen now. So what else can we look at with prevention? You start with baseline testing, you move to your clinical care, you go to return to play, and you go to education and awareness. I think it should really start with education and awareness. I kind of started that on the wrong thing, but if they have the information of what can happen following a concussion, they're going to be more likely, I would think, to report it to you, because I always use the analogy that you can replace your knee or you can replace your shoulder, but your brain's arguably the most important part of your body, and you can't replace that. So the second you're having subconcussive blows to the head or concussive blows to the head and you're suffering those symptoms, you're putting yourself at a greater risk of long-term impairments. So kind of in summary, the biggest thing with both concussions and late life impairments are recognition. So if you can recognize a concussion right off and treat it and diagnose it and manage it, and all of that goes well, then great. That's awesome. You're putting them at a decreased risk of further injury. You're putting them at a decreased risk of late life impairments. If you can recognize the impairments, so kind of when we went through any of those trademark signs and symptoms, go back to the football players who had been diagnosed, with CTE. If they were somebody that was always on point and all of a sudden they're forgetting things and their cognitive function is decreasing, you might want to look into them. I've used the analogy, the person that loses their keys every single day, or the person that misplaces something that they use daily on a regular basis. Those are the people that, where they may not have any issues, you want to keep an eye on them, and you probably want to get them to the doctor in case you can slow down those symptoms from occurring. If they have psychiatric symptoms, if they suddenly become paranoid or they start having a lot of panic attacks that they didn't have before, or you have somebody who's always been a positive person, they've always been happy, and all of a sudden they've been depressed for months, and they're not telling you about it, get them to the doctor. You'll see social withdrawal as a sign of some of these late life impairments where they were social for their entire life, and then all of a sudden they wanted to alienate themselves from everybody. I recently read an article about this football player who had a lot of promise. He grew up in Kentucky. He got a scholarship to one of the D1 schools, I don't remember which one, played a season, and retired. He had one really bad concussion during his collegiate career and said he was done, by choice. Within 5 or 10 years, he was experiencing these symptoms. He was married to his college girlfriend. They were living together. They went from hanging out with their friends all the time to him not wanting anybody to see what he was going through. He was losing his keys constantly. He was having crazy mood swings. All of these things were happening, and when he died, she donated his brain to research, and it came out that in his it was either late 20s or early 30s, he was showing some advanced signs of CTE, and it's one of those stories that you kind of hear about on the news of, oh my God, this young guy had CTE, where, yeah, those cases at this point are seemingly rare. I mean, you have had the high school athlete who was 18 and showed signs of CTE on the scan that I showed you earlier, but at this point, those are rare, and we don't know which athletes are going to be at a greater risk. This could partially be genetic. I mean, you're at a genetically higher risk after sustaining a concussion of potentially having a form of dementia, but those are just things that you want to kind of keep in mind. And the prevention aspect is just early recognition of anything. If you can recognize any disease early, you're going to slow it down to some degree. Or you're going to hope to slow it down to some degree. You can't slow down everything, but early treatment's key, especially with any of these dementia or depression aspects of things. So that kind of sums everything up. Just to recap the series before we wrap up here. In the first section, you learned about epidemiology. So we discussed about 1.6 to 3.8 million concussions occur annually. However, it's likely more, since 50 to 70% go unreported, and an epidemiology study of sports-related concussions has not been done since 2006. In the second part of this, we discussed evaluation of concussion and the importance of baseline. We also discussed the limitations of the exams that we currently utilize, such as practice effects, and we went through IMPACT, FAST, which is the Balance Error Scoring System, SAC, which is the Standardized Assessment of Concussions, and the King-Devitt test, as well as a graded symptom checklist. We chose these tests to go through with you because, according to a recent study, they are the most commonly utilized tests across the medical field, and they are the tests that I am most familiar with as well. So I wanted to be able to give you guys the best information possible. In the third section, we talked about return to learn and return to play, and how they should be stepwise protocols and somewhat individualized to the athlete, especially with return to learn. We want to make sure that our athletes are getting the best possible care, and we also want to make sure that they are being treated as student athletes and that their academics are coming first. Return to learn is still a relatively new concept, and a lot of schools are lacking protocols at this time, but in a few years, I'm sure we'll see some differences. And then in this lecture, we discussed late life impairments and how they're related to concussions. Thank you again for tuning in to part 4, late life impairments in relation to concussions, of our concussion lecture series. If you have any questions, please do not hesitate to contact me at Cassie with a K at precisionat.com. Please make sure that you fill out your evaluation forms and your course forms, which are attached to the same webpage. Megan gave you the instructions in the beginning. If you have any questions on that, you can also email us. Megan's email is mhunt@precisionat.com, and our company phone number is 781-366-1880, and you can call during normal business hours for any questions related to CEUs or CEU home studies or becoming an independent contractor for us. If you are not currently signed up for emails and you want to hear first about concussion CEUs or home study CEUs or our nutrition CEUs, we also have some evidence-based practice stuff coming up, then please visit www.precisionat.com and apply to be one of our people, or you can message or you can email Megan or I. You have our emails at this point. If you are local to the area and you are looking for some extra money or per diem opportunities, then please contact us. It's really easy to go on our website and hit apply to join Precision AT, and you'll have to fill out some information, and then we'll check your references once you apply for a job. The jobs are easy. It's a job email. It's first come, first served, so it works out really well. If you need CPR and you're local to the Massachusetts area, we offer CPR every month in Boston, or you can contact us and we can set up an appointment for you, and it'll be more of like a one-on-one session. We allow you to do the online course first and then just do the test portion there. So without further ado, I hope you have a great rest of your night. And again, if you have any questions, please do not hesitate to contact either Megan or I, and we will get those answered for you.